Thank you, Jeff, and thank you, Haro, for the invitation to be on the podium. It's a pleasure to be here today. I was asked to talk over the next 20 minutes or so about the preventative ablation, does it work? And what I'm talking about today is, does it work for preventing Barrett's from progressing into something worse like adenocarcinoma? I think I'm going to have the same issue with, point it that way. Point it that way. There we go. So these are my disclosures. Actually, Covidien, as you may or may not know, bought Barrett, which is the company that makes the radiofrequency ablation catheters that are most commonly used for ablating Barrett's esophagus. I have done speaking for Covidien for hernia. I've never done it for the Barrett's topic, so I'll manage that potential conflict by sticking to the data, and it's a topic I don't get paid for to speak with for Covidien. We've been talking about Barrett's. We know that intestinal metaplasia is a change in the cell type that lines the esophagus. It changes from a squamous epithelium to a specialized intestinal one, first described by Norman Barrett in the 50s, actually related to the esophagus by Allison and Johnson. And as we all know in this room, it's a known risk factor for esophageal carcinoma, which is why we've been talking about how do you biopsy and what intervals should you use. Because of that risk factor, lots of things have been used over the years to try to get rid of this stuff short of surgery. And this is a whole laundry list of options for trying to get rid of Barrett's esophagus. I'm going to concentrate today on two. The first I'm going to talk about is radiofrequency ablation, and then I'm going to spend some time on cryotherapy as well. These others are either a bit of over-treatment. We don't need to do EMR for non-dysplastic flat Barrett's esophagus, and some of the others have fallen by the wayside. So let's talk first of all about the concept of mucosal ablation in treating Barrett's esophagus. When we talk about mucosal ablation, we're trying to get a controlled destruction of the epithelium in the esophagus. And what that means is we want to destroy the epithelium down to, but not through, the muscularis mucosa. If we can keep our ablation to that depth and out of the submucosa, then we start avoiding the complications of stricture or worse. EMR is obviously an overtreatment for Barrett, since this is a disease that's confined to the epithelium. The radiofrequency ablation of Barrett's esophagus has really revolutionized how we manage this disease, particularly for high-grade dysplasia. And I want to explain a little bit about how that's done and then go through the data on supporting that use. The first system to come out for radiofrequency ablation was this balloon-based catheter, which was made by a company called Barrett. And this is a catheter that allows for circumferential ablation to a very controlled depth. A magnified view is here, and you can see these little bands. So this is essentially bipolar electrosurgical energy. Not a lot different than what you use on your typical Bovie machine in the OR when you're using bipolar. A bit more sophisticated in that this device can monitor impedance, and it also knows how much energy is delivered. But it's a similar concept in electrosurgery. It's very high power and rapid delivery, which is what allows you to get this controlled ablation down to, but not through, muscularis mucosa. And the way that we do this is we first identify the treatment zone by doing an endoscopy, and then this balloon is passed into the area of treatment. Now, the balloon is not small enough to go through the scope, so this is a side-by-side technique where the balloon is in position and we have an endoscope next to the balloon monitoring where we're placing it. The ablation is quite quick, so in a very short period of time you get a circumferential 3-centimeter ablation, and you can overlap these ablation zones so that you can progress down the esophagus. And maybe in the discussion section we can talk about kind of lengths to ablate in one session. Here's a water tank demonstration of the catheter just to give you an idea of how quickly this will work. And so when you push on the foot pedal, in that period of time, you've just ablated 3 centimeters of esophageal mucosa down to, but not through, muscularis mucosa. It became clear in the process that not everybody needed a circumferential treatment, or as you progress through treatment, you didn't need to come back and do a circumferential. You just wanted to do a little touch-up. And so the Halo 90 system was developed, which, as you can see, mounts on the endoscope, kind of pivots, and you can do spot treatment with this device, the exact same type of energy delivery. And when we're doing this in the endosuite, this is the immediate mucosal appearance, so you can see the baseline to your left. And then after the first treatment, you get this very well-demarcated treatment area, which allows you to line up sequential treatments if you're doing long segment Barrett's esophagus. So let's talk a little bit about the data that says that this is a good thing to do for Barrett's esophagus. There have been a lot of trials to study this. It's been an extensively studied technique and technology. Our group, when I was at the University of Miami, did the first pilot esophagectomy study as part of a multi-center study. And you can see that a lot of data continues to be generated, including a national registry for patients that get treated with this device. But the data that really kind of caused the medical world to pivot on the use of using radiofrequency energy for high-grade dysplasia came out really at this time 4 years ago. And it's completely changed how we manage Barrett's esophagus with high-grade dysplasia or even intramucosal carcinoma. So a half a dozen years ago in our center, that was treated with esophagectomy. Nowadays, that's just not treated with surgery. We use a combination of endoscopic mucosal resection techniques, which you're going to hear about in the next talk, and then we take care of the flat disease with ablation. And this was the article that really supported that use, published in the New England Journal of Medicine in 2009, a very nicely designed prospective randomized study out of Nick Shaheen's group. And what they did is they took patients with high-grade dysplasia and they randomized them into RF ablation versus placebo. You can see there were 127 patients. These were expert centers that were experienced in using the device, and they had a minimum of 1-year follow-up, although we have up to 3-year follow-up from this study now. And what they found was that if you had low-grade dysplasia, over 90% of the time they could eradicate that, and that was durable up to a year using radiofrequency ablation. Versus sham, which was about 23%. High-grade dysplasia, a little over 80% eradication versus 19% sham. Some of these patients in this trial were continuing to be treated, and so some other studies show that that's even a bit higher for the eradication rate for high-grade dysplasia. But that's a typical range that we get into. Progression to cancer. Did you progress to cancer while we were putting you through this radiofrequency ablation program? 1.2% of patients progressed using RF, 9.3% sham. All of those were rescued using endoscopic techniques. The progression of disease, of any disease, so did you go from no dysplasia to dysplasia or from low grade to high grade, was 3.6% in the RF group versus 16% in the sham. And actually in over 77% of patients in this study, they got rid of all of the intestinal metaplasia. So not just the dysplastic stuff, but all of your stuff. And so that seemed to be an effective treatment for RF. Low complications, there were 6% strictures. These strictures were not the photodynamic therapy strictures that we used to see of old, which could be quite difficult to manage. So on average, these patients required 2 dilations to manage that stricture. And this study also pointed out something interesting that I don't think we really understood up until this point of time. And that is the concept that buried glands are actually part of a natural part of the Barrett's esophagus. Typically, endoscopic therapies were evaluated on whether or not there were buried glands later in the surveillance of those patients. And if you had buried glands, it was felt that that was a bad thing because you got this normal mucosa that regenerated after your ablation on top, and underneath that is hiding these buried glands. Turns out that at baseline, 25% of these patients who had never had anything but medicine for their Barrett's had buried glands. So that seems to be part of the natural process of this disease. Certainly RF decreased that from 25% to 5% versus sham, where they continued to progress to up to 40%. So really, based on that study and others, the current status for using radiofrequency ablation for Barrett's esophagus is that it's pretty much been accepted for managing high-grade dysplasia. The controversies now are, what do you do about non-dysplastic Barrett's, and is that appropriate to be ablating? And when you do ablate patients, how do you follow them? because this is not a one-and-done therapy. These patients need multiple sessions to achieve complete ablation, which should be part of your selection process when you're talking to a patient. You're going to be friends with that patient. They got to be able to come back on a regular interval to get both ablated and then surveyed. So let's talk a little bit about should we be doing benign disease with ablation. And to have a meaningful discussion about that, we need to understand, well, what's the risk of benign disease turning into something bad in my esophagus? Many groups traditionally thought that benign disease really was just that and that this wasn't really a significant risk. This is a nice article published by Sharma back in 2006 now. Took 618 patients that at index endoscopy were found to have intestinal metaplasia. So they were their first diagnosis, 600 patients with their first diagnosis of intestinal metaplasia, and then followed them for 4 years. All of those had non-dysplastic Barrett's esophagus. Over a 4-year period of time, 3.6% of them developed high-grade dysplasia, 2% of them developed at least intramucosal carcinoma. So if you break that down, that's a 1.4% chance per year of going from non-dysplastic Barrett's esophagus to a condition that up until when we had RF ablation, we were taking your esophagus out. If we compare that risk to colon polyps, a colon polyp has about a 0.58% incidence per year of progressing to colon cancer. I just told you that Barrett's has a 1.4% chance of progressing per year. We've accepted screening colonoscopy as a reasonable therapy for polyps. We need to think about what we're doing for benign, what we call benign, non-dysplastic Barrett's esophagus. And this is an interesting evaluation of over 65 studies done by Wani and published a couple of years in the American Journal of Gastroenterology, looking at how many patients would it take to get to save somebody from developing cancer if we were ablating all of these categories, non-dysplastic Barrett's esophagus, low-grade or high-grade dysplasia. And the literature seems to show that for non-dysplastic Barrett's esophagus, which by the way is the easiest condition to ablate, we can get nearly 100% ablation success in that disease. You could go from 0.6% to 0.16% in its natural history. That means you would have to treat 45 patients to save one patient from developing esophageal cancer. If we look at low-grade dysplasia, it's about 13. If we look at high-grade dysplasia, it's about 4. If we look at that in comparison to a polyp, it looks like even for non-dysplastic Barrett's esophagus, you're still in that range of what we're doing for patients with polyps. It takes about 38 patients with polyps before you saved one from progressing to carcinoma of their colon. About 45 for non-dysplastic Barrett's esophagus. So there seems to be at least a logical argument for ablating non-dysplastic Barrett's esophagus. Doing this routinely is not part of our day-to-day practice outside of study protocols right now, and the society position statements are not yet supporting this, but I would encourage you to keep your eye on this disease because as we get more data and more long-term follow-up, we're going to be able to give you more meaningful advice about whether this population should be ablated or not. The other thing is, okay, what's the risk of recurrence? I ablate you, things look good, now what do I do? How long do I have to follow you? Can I take you out of the surveillance cycle? And we've got some data out there that says that you can't take these patients out of the surveillance cycle. So this is a retrospective study looking at 119 patients that had a combination of high-grade dysplasia and maybe even intramucosal carcinoma. They were all treated successfully with ablation, and then they were followed. And it turns out they had about a 5.2% annual recurrence rate. Now, fortunately, they weren't progressing in their disease, but they were recurring. You can rescue over 80% of these patients with endoscopic techniques, but you can't stop surveying them. That also is supported by a nice study that was presented at DDW last year, looking at 155 patients prospectively that had complete eradication of high-grade dysplasia and intramucosal carcinoma. So these were patients that came in and had all of their high-grade dysplasia ablated and had their intramucosal carcinoma ablated as well. They were followed out for 3 years, 36 months, and with a surveillance cycle of every 3 months surveillance. What they found was 40% recurrence rate. And you can see the different grades that recurred. Most of it is non-dysplastic intestinal metaplasia, but that recurrence rate tended to happen in the first 22 months or within the first 3 EGDs. So this group argues that for at least the first 2 years, you got to continue to survey these patients, and you should probably do it if you're following high-grade dysplasia at a 3 to 6 month interval, just as if you hadn't treated them at all. The recurrence tends to be at the squamocolumnar junction. 71% recurred at that area. That's the hardest area to treat. We spend a lot of time using the Halo 90 and treating that area so that we make sure that we get a complete treatment at that site. And so their conclusion was you got to follow these patients and you have to pick up these recurrences so that you can retreat them. Now just a word about cryotherapy in the last couple of minutes. This is another method of treating mucosa, of ablating mucosa. It's what I call a point and shoot technology. So rather than applying a balloon to the area or kind of a paddle to the area, now we're pointing and shooting with the device. If you look carefully at the screen, it's easiest to see on this one. That's an NG tube or an OG tube. So the cryogen expands rapidly when it gets to room temperature, and if you don't vent the stomach, you can actually rupture the stomach, and that's happened on a couple of cases. So you need to vent the stomach, and then you need to do point and shoot around the catheter in order to treat. There are there's interesting discussion about what's the mechanism of action here. It's a little bit different than thermal ablation like you see with radiofrequency energy. You get this periphery lesion which does not have immediate cell death but does die by apoptosis later. And there's some theory that that can activate the immune system, and maybe that's a good thing for long-term keeping this stuff from coming back. There are a couple of different systems out there. And the data is actually, the reason why I'm spending just a short period of time on it is there isn't a ton of data out in the literature about this. Initial data from Dumont's group and Johnston's group was quite nice. You're seeing that you get anywhere from about 75 to 90% ablation depending on the degree of dysplasia. These are very small studies, 10, 11 patients in the study. One of the bigger studies out there is this one from Shaheen, nearly 100 subjects that had Barrett's esophagus with high-grade dysplasia. They had 60 patients that made it all the way through the treatment regimen. Pretty low complication rate, 3 strictures, no stomach problems with venting the stomach. Short-term follow-up, which was just over 10 months, showed that they had a very high eradication rate for high-grade dysplasia and pretty good 82% eradication of all intestinal metaplasia. So it's an interesting technology. The data is evolving. Some people feel that technically it's a bit more difficult to administer. The interesting thing is this difference in how it ablates the tissue and the fact that you can take care of nodules with this disease, which the RF devices are not good for treating nodular disease. That has to be taken out with another means, and you treat flat disease using the RF catheters. So kind of in summary, if I go through the points, high-grade dysplasia is really now being managed with RF ablation and in selected centers with cryotherapy. And it's completely changed how we're managing these patients today. The jury is still a bit out on non-dysplastic Barrett's esophagus, so that wouldn't be the first group I would rush to if you're starting to do this. But keep an eye on the literature. I think in the next few years we're going to get more long-term answers about whether we should be ablating that or not. We heard about the controversies of low-grade dysplasia, and I would just say the short answer is make sure that you believe that diagnosis, and if you do, it's probably a reasonable set to ablate. And we're going to hear in our next talk how to manage nodular disease, which is really not part of what the RF catheters can do. They manage flat disease quite well. Again, thank you for your attention and the time on the podium. I don't know if we have a minute to answer questions now, or we can do that in the discussion section later.
Okay, thank you, Brian.